Assalamu alaikum. Good evening. Welcome to our webinar. My name is Samah Zaid, Pharmacy Director in Gurayat General Hospital, and I will be serving you today as a mediator. We will be hearing a presentation from Dr. Yusuf Al-Aoumi. He will be speaking to us on new modalities of medication error prevention within the new vision of Saudi. Dr. Yusuf Al-Aoumi, former head of General Administration of Pharmaceutical Care Administration, former head of National Drug Information Center, former head of Research and Development Department at Pharmaceutical Care Administration at Ministry of Health, Saudi Arabia. Dr. Al-Aoumi is a product of King Saud University, confirmed with the degree of Bachelor of Pharmaceutical Science in the year of 1992. After 6 years of higher study, he earned his Master of Clinical Pharmacy from the same university in the 1998. He is an affiliated clinical instructor of Purdue University in the USA. He is adjunct assistant professor at King Saud University College of Pharmacy. Now moving along to our session, please welcome to deliver the presentation on this very timing subject. For any question, you can put in the box, the Q&A. You can start, Dr. Yusuf.
Okay. بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاة والسلام على أشرف الأنبياء والمرسلين نبينا محمد وعلى آله وصحبه وسلم تسليما كثيرا. Just good evening. And initially, I wish to thank Saudi Patient Safety Center for this organization, this session, for several serious sections and presentation about medication safety based on World Patient Safety Days. And it's my pleasure to be with you today. And also, I will thank all the staff of Saudi Patient Safety Center, all the staff without differentiation. And also, I will thank Dr. Samah for moderating the session. I will discuss something about, I can say, new modality or prevention of medication error. I don't have anything to close with you. And we'll discuss something about introduction. And by end of this presentation, I hope to be familiar with the medication safety requirement, some requirements, because the requirement of medication safety is very huge. I'll pick points, some requirements standard, or some requirements should be available for all pharmacy practice and also for healthcare organization. And also our objective to be by end of this session to understand self-assessment medication safety, know the new technology of medication safety or prevention medication error, and to be familiar with the human resources requirements and recognize the pharmacy quality management and realize patient satisfaction. And one of the several modality prevention of medication error, then we'll ended up by the conclusion. Just will pick up your mind about all the prescription that you can find in the practice, and also some primary care center, privates, and also some hospitals. Still, they have some prescription like this way. You cannot read it. You cannot familiar with all the terms. A lot of mistake is there. I will give you something about what's the requirement of medication safety as a generally. This is survey has been done before almost 5 years back, about National Survey of Pharmacy Practice in a hospital, and almost more than 100 hospitals. And we come up with several modules of surveys. Part of it, how to prepare medication and dispensing. And we asked the people at that time about drug distribution system. Drug distribution system that being used in outpatient and inpatient, and drug distribution unit dose system or single unit dose system they're using in an inpatient pharmacy. And now all the people, they are using now unit dose system. Unit dose system, they are they initiated or established to prevent any drug-related problem and avoid any additional economic burden to healthcare costs and pharmacy practice. And we found only that we had 34% of the surveying hospital, they have complete unit dose system. We asked the people at that time about intravenous admixtures. How many do you have complete IV admixtures? And we have, I can say, 78%. They don't have any complete IV admixture. That means how to prepare medication, how we reconstitute medication, the standard concentration, how can you inject the patient. All these, it's not exist, and this is may prone to the medication error in the practice. And also, we asked the people the method of using to assure the accuracy of preparation and dispensing. And we found we have almost, I can say, more than 40% to 45%. They have only one pharmacist of checking a drug order. And some of them, 10%, they don't have any checking system. They don't have double checking system. You don't have some prevention of medication error may lead or more prone to get error or incidence of error. And also we asked the people about what the new modality, what's the technology you are using in the pharmacy practice to prevent any medication error. We asked about, do you have computerized physician order entry or electronic prescription? Almost you can find the result almost not exceed 35%. It's almost around 25, 35% to have. Otherwise, we don't have more than that. In the United States, they reach almost 95% of the computerized physician order entry. Another question has been delivered to them. What about, do you have drug alerting system? Drug alerting system, that means if you have any medication error, any drug-related problem, they give you alarm to prevent or stop any progress of medication error. And we ask them, do you have alerting system? Most of them they don't have, and almost just only 1/3 of our surveyor, hospital, or healthcare organization, they have alerting system. Otherwise, we don't have during that survey. And also, we asked the people how many new technology of drug distribution system do you have in robotics? Almost more than 80%, they don't have it. And we asked the people about, do you have any planning to be automated in the future? At that time, 60% didn't have any plan to be automated in the future. Another study we have done it, we asked a physician about adverse reaction, about physician knowledge of adverse reaction. We found almost 50% they are not familiar with the adverse reaction. If the people not educated, not teaching about adverse reaction, how can they report it? Definitely, they will not report any adverse reaction as a part of the medication safety. Another thing, which is this study has been done also to evaluate the medication safety knowledge among the dentists, and we found almost 60% of them, they have medication safety knowledge. Otherwise, more than 40%, they don't have any knowledge about medication safety. This is very, very important, lead to us to be concerned about medication error and how we prevent in the future, and how can we stop all the progress of medication error. And another study that we have done it, and is to prevent after implementation of medication safety, how it's cost avoidance and how prevent economic burden. And within almost 12 months of the implementation of medication safety program, they found to avoiding of the cost or prevent almostly more than 110 US dollars per year annually for just one hospital. What about if we expand all the requirement of medication safety? That means you will prevent a lot of medication error, and you can prevent and you can avoid a lot of economic burden in the healthcare organization. General statistics about medication error occurs. I will explore several studies on the systematic review. That means systematic review, they contain several studies. And the error rate, they found it from 7% to 90% of prescribing error. And also for administration need to the 80%. And the most of common type of prescribing error or reporting incorrect dose with incidence to up to 34% of the prescription, followed by wrong frequency and wrong strength. And this is exploring the dosing error and how much percentage with a different country and different study in Arabic country. Another studies just before 2 years published with almost 45 studies, and they found the prescribing error were reporting as 91% with the primary care center, and they found the prescribing error rate from 7 to 56% medication error. Adverse reaction they reported to care from 8 to 16% per each 100 admission after including drug-related problem leading to the admission to the organization. Another recent study in the Middle East with the 18 article, another systematic review, also the same thing, almost the prescribing error reached to the 50%. And including general prescription error or omission error, it's a huge problem. We need to prevent and stop it, progress of medication, because the progressing of medication may lead to the patient, we call it sentinel event of death, or lead to patient to be died. Another concern about the important medication error, what's the cost of medication error? This survey has been done it, and we distributed to the patient and healthcare professional. It's I know it's a small sample, almost 200 of the 200 subject, 155 the general population, and 55 healthcare professional. And we asked them at that time, have you even exposure to drug-related problem? We identified the medication error, medication adverse reaction, drug poisoning, non-compliance, medication without indication, drug interaction, all the drug-related problem according to the classification, according to the American Society of Health System Pharmacists. Have been exposed to the any one of them? How many frequency per year? How much does it cost? And we found that the average cost reached to the $122 million annually. They cost us, if we extrapolate the data for all our population. It's that result. It was very impressive to our authors, and it was almost comparable to the United States with all the study. Otherwise, recently the new study in the United States doubled the cost. They reached to that 300 million US dollars. But this is very, very important. The cost of medication and economic burden is very huge. What can we do to prevent all medication or to expand medication safety? One of the you need to diagnose, you need to assess your medication safety, you need to assess your medication error. One of the famous institution, they call it Institution of Safe Medication Practice. Before 7 years back, we have a contract with them to make assessment of the medication safety in our for our hospital, and we have done a several survey. And the medication safety self-assessment, this organization, they have multiple assessment. They have medication self-assessment for preoperative setting. They have for high alert medication. They have antithrombotic medication. They have for community ambulatory care. They have self-assessment for oncology and for the hospital. What we have done it for hospital and for community and ambulatory care. And they have classified the assessment for 10, they call it 10K element, starting from patient safety until quality perspective and risk management, including drug information, drug labeling, packaging, standardization. And each one of them, they have listed the question. They are asked you, do you have it? Or if you have it full, all the components, you can answer 5. If you don't have it, no, you can answer with the 1. And you can assess yourself. And we have a survey, and we started with the Kingswood Medical City at that time, 2008. They will repeat it again at Ministry of Health with a 22 hospital, and we have the patient information that the least percentage we came up with, and medication devices acquisition and monitoring, because medication device is very important. You need to adjust it. If you want to start smart diffusion pump or other devices, you have to adjust it and manipulate it according to the guideline. If you're comparable with the United States result, 2000, 2004, and almostly, I can say it's comparable, reach. Otherwise, United States little bit higher than, better than us. This is now, you diagnose your reason of propagate of medication error. We have something missing of patient information. You have medication devices, you have to manipulate it, you have to correct it to prevent any medication error. And then we extrapolate and we try to expand our ISMB national survey, and we have adopted a system for primary care center and community pharmacy, and we distributed and we assessed about the percentage comparable with the United States. And I can say we are proud. We are the first country in the world they assessed with the safety ISMB medication safety in primary care center, and we have a certain percentage, and almost comparable with the United States, and also with the community pharmacy. We found it certain percentage, sometime comparable with the like environmental factor, workflow staffing, almost I can say 71%, and all in the United States 78%, and almost comparable or equal as it is in the United States. This can give you something. The primary care center, they have basic foundation of the medication safety, but you need to work with it to improve the medication safety environment and all factors to prevent medication error. And on top of that, we try to apply medication safety assessment and during Hajj period, and we found it's better than what have been reached to the hospital, and better what have been found in the primary care center and community pharmacy, maybe almost sometime better than United States with some percentage, like patient education in the United States 68, while we have a 75%. We have, because our staff or healthcare organization, they did excellent job during Hajj with the patient counseling and patient education. Environmental factor and workflow almost the same. Maybe we are better than them. We have 78% comparable with the 77%. That means during Hajj, our staff or our health organization, they focus very hugely on the medication safety to prevent any medication error in the future may occur in the future. And another dilemma as a part of medication safety, American Society of Physicists, some pharmacists, they organize what's called the Standardized for Safety Initiative. Each medication or parenteral medication, they specify what's the concentration, standard concentration, what's the rate of administration. It should be standardized for all the people to give the patient. And what we suggest to standardize, it's not only medication, not just only medication, all medication, including medication, emergency medication. And it is not matter of standardization. No, we come up with what we call it physician order form. That means the physician, he can choose one medication. They can choose the standard formula, how much milligram you need to dissolve it with the E5 photo, normal saline, and how can we give it peripheral line or central line, and what's the date of administration. This can make the life very easy for physician and prevent a lot of medication error in the future. And this is listed of the medication of emergency for adults and also for neonate and pediatric with standardized concentration. And we put it as a physician order to push the physician, healthcare provider to follow up it and fill it. This one, if we convert it as a computerized, it will be very wonderful, and the physician, he can follow it step by step, because in emergency and in ICU, they have a lot workload and sometimes a busy workflow, and a lot of mistake may occur in that situation, and you need to make life easy for the people and tell them this is the roadmap to prevent any medication error. And if you make like this one, you make life very easy to them and to prevent any medication error. And as a part of for safety of standardized safety, and we suggested to be all the medication should be standardized concentration. Like for example, an antibiotic for intravenous infusion, it's not a matter of the standard concentration or standard rate of infusion or standard maximum concentration. We suggest how much volume you need to dissolve. What's the dose, and what's the including concentration, the strength of medication, and how much you dissolve it, normal saline or D5 water, and how much you give the patient, and rate of infusion, and the stability. This is, we exceed the for safety for standardized in the United States, because they are put it as a concentration rate of infusion. But we suggested also to put it as what the volume should be included and giving the patient. And we consider the dose of the patient, the frequency, and also the strength fire came from the manufacturer. For example, if you have a mecacin is coming of the 500 milligram and 100 milligram. It doesn't need to give the patient, let's say 450 or 400, 400 and 100. Sometimes an adult doesn't make anything if you just put all the ampule and not throw and cost you money. Put it in 500 and give him in 100 cc normal saline, 200 cc, and according to the standardized, this is you make the life easy, and looks like you give pre-mixed medication. And we suggested all the pharmaceutical company to make all the IV infusion as a pre-mixed to make life easy to the patient, make life easy to the healthcare professional and the pharmacist and the nurse to prevent any medication error in the future when you administer the medication. Also for antibiotic for pediatric, the same thing. We suggested standardizing of the all medications according to the dose and the vial. Additionally, the Ministry of Health, they have several guidelines: DV prophylaxis, pain management, antibiotic prophylaxis, electrolyte. That's excellent job that has been done, but we need something or roadmap to tell the physician this is the situation, this is the map you need to follow to prevent any medication error in the future. And we suggested the physician order standard consultation as a form for replacement therapy. And we designed a form, IV electrolyte replacement, according to the, for example, potassium phosphate, magnesium sulfate, calcium gluconate, and sodium phosphate. And we suggested, according to the diagnosis, what's the level, what's the suggested the concentration or the amount of you need to give the medication of potassium chloride, and how much you dissolve it in volume for volume, and how much rate of infusion. And this one we converted in one hospital to the, instead of you put potassium chloride 2 milliequivalent per ml, no, we remove it and we put potassium chloride 20 milliequivalent per 100 normal saline, potassium chloride 20 milliequivalent by 500, and etc. And the physician, he just choose it. Once he choose, you can prevent all the medication error and confusing for pharmacists, for nursing, for everything. This it can make very easy to the physician to choose anything among all the strength of medication, and he can very easy to count the potassium they give the patient, they count the magnesium how much, and we put it as the common practice use for grams or milliequivalent or millimole, whatever. We standardize it as a millimole as a rule of thumb for all electrolyte except the calcium gluconate, because the normal dosing it's coming with grams. And the same thing for we designed for neonate and pediatric replacement therapy. And nowadays, a lot of people, they are suffering from non-available medication. And we suggest it now too, because if you not give the patient any medication, that means lead to the progress of disease. If we set up what we call therapeutic interchange, and therapeutic interchange, and we suggested several group of medication you can therapeutic interchange. Looks like what's recommended by Saudi FDA. And what's the first solution? What's the second solution? If the Cipiclor is not available, how can I replace it? And which medications and how much the dose? If you make it as very life easy and make it as a table and let the people very easy to interchange and choose. If not, this drug does not exist, he can choose another one, and etc. This can expand the knowledge, and also they can choose the medication, and it will not progress the disease anymore in the future, inshallah. Because sometimes some missing, any mistake is happening. Sometimes there is some company not producing enough supply, whatever the reason. You have interchange, you can replace it by each other of less medication. Well, just to give you an example of antibiotic. Otherwise, we published several group of medication like antibiotic, chemo, and cardiovascular medication, neurovascular medication, etc. And infection control, we suggested to implement the program of infection control pharmacists, because we found a lot of mistake happening as a contamination of the IV product lead to the septicemia to the patient. This is what we found in the literature, and this is very important to establish what we call the infection control pharmacist to prevent any contamination related issue in the product. Another thing, a lot of people, they wish to fasting during Ramadan, and a drug-related problem may occur, especially if you have a diabetic patient. If you have patient infected, and some people, they are break fast the fasting, despite of physician advising or pharmacist advising. Most of the people that wish to fast and break the fast, instead of practicing the fast, you can replace it, and instead of short acting and more frequency medication to give him long acting or less frequency, they can use it in the during Ramadan. And we have conversion as a guideline during Ramadan. If you establish, that means you can prevent a lot of medication error. And additionally, also in the a lot of huge program we suggested for mass gathering at healthcare institution with the different section, different sector, and the pharmaceutical care services. And recently, we suggested a program for outsourcing pharmaceutical care, because the percentage of the IV admixture leads to the it's almost just 30%. But if you have outsourcing, if you have a outsourcing company, they can prepare it, they can sell it to you, and instead of establishing a big foundation of IV admixture, that means it's less cost to you, more convenient, and very fast, and you can saving money, you can saving human resources, and instead of you establish everything and take a lot of time if you want to establish IV admixture or another services. Another solution for preventing medication error, it's a new technology. We need it for patient safety and pharmacy efficiency and inventory management, and for cost tracking and pill management. And they are enhanced safety. 78% of dispensing error can be avoided by using automated system, and also they reduce the dispensing error by 50%. And several automation you can implement it in inpatient and outpatient, like automated prescribing, automated dispensing cabinets, a lot of things. Just to give you some picture, this is the flow if you want to implement pharmacy pharmacy automation, starting from just bulk stock solution until reach to the patient. If you need, or if you're using all the technology and for exchange chart, dispensing cabinet, and point of sale, point of care verification to prevent all the medication error, starting from pharmacy to the nurse to the patient room. This is the type of automation in the market, the unit dose system they are using, and I think most of pharmacy practitioners are familiar with, to prevent any medication error, because everything is automation and computerized, and there is no handwriting at all, and all these can double check. You can verify code, coding, and everything. It's wonderful if we compare to the full pharmacy automation, but each pharmacy practice services, they have to evaluate, to assess according to bed capacity. Do we need this equipment or not? Accordingly, you come up with the conclusion, which system shall I choose to implement it in the pharmacy practice. And finally, we suggested the WASFATI. In the state, they call it managed care pharmacy. So, and we call it as Saudi managed care pharmacy as a new initiative before almost 5 years back. Nowadays, we have a WASFATI, electronic prescription. This one can prevent a lot of medication error. You cannot find handwriting, missing abbreviation, missing of the names. No, you can find everything line computerized, printed, messaging sending to the patient. That can prevent a lot of medication errors. This is another parenteral solution robotics, and instead of like oncology preparation by pharmacists, they have some robotic. They can prepare all the IVF picture, including TBN. This is the cycle you can find in the practice, starting from unit dose and TBN compounding, and also for smart infusion pump, they're connected with the computerized. And finally, they are using during Corona epidemic season for the telepharmacy and contact with the patient. This is in the patient counseling, kind of prevent a lot of medication error as a part of new technology. And top of that, some our institution, they're using healthcare applications like Tawakkalna, Sahati. All these now you can find the list of medication is there, and some program they connected like Cerner, EVIC, and some software they're connected with the healthcare application. They can prescribing and entering a prescription during any emergency situation, anywhere, wherever, whatever, anytime you can. If instead of call the physician and come, and with the crowded area, maybe accidents occur, he can access it and he can prescribe the patient by new technology implementation. For the human resources, and we need somebody to prevent medication error. If you involve a clinical pharmacy, you can prevent a lot of medication error. This is study has been done at King Saud Medical City. Well, at that time, we have 10 clinical pharmacists with almost 5 months, and we documented how much cost avoidance from drug formation, for poisoning, for other clinical pharmacy services, and we found for each $1 invested, you will save monthly almost $100 if you employ the clinical pharmacist. That means we need highly recommend to employ the clinical pharmacist, and I wish to thank all higher university and higher education Ministry of Health to convert all the education instead of bachelor to the PharmD, that we can graduate. And also I wish thank to Saudi healthcare professional to be educate for residency, and this is can educate and a graduate clinical pharmacist. They can involve and prevent medications errors. And this is an example. This study has been done in one private hospital, and they found a huge, tremendous of saving on the medication error once you involve a clinical pharmacist in the critical care. And this is the economic impact. And annually, you can save almost 440,000 US dollars annually just for critical care. What about if you expand the clinical pharmacy? This is including preventing medication errors, suggesting new medications, suggesting prevent any appropriate dose, TBN consultation, and etc. And this is another study for inpatient medication error and what's the role of pharmacist intervention and prevent medication error. Most of the medication error was prevented, and most of suggestion was accepted by physician and healthcare professional, and they can reduce the medication error very tremendously. The economic impact, almost the same thing. In 1 year, they can save more than 500 US dollars as cost avoidance of the medications error and drug-related problem. And if we explore the demand of the hospital pharmacists, we have a very high shortage of demand. This is the total number of pharmacists per hospital at that time. We have very shortage of staff, and this is for all the hospital. The same thing, we have very shortage, and we recommend how much, what's the hospital pharmacist demand for coming years, and what our suggestion for forecasting, how much do we need for pharmacists to be graduate and involved and employed in our healthcare institution for all the level for healthcare professional, especially with emphasis to the hospital pharmacist. For pharmacy technician is another thing. We need a pharmacy technician. Now, currently, the pharmacy technician graduation or organization or education, it's abundant. They abundant before almost 7 or 10 years now, but I think now we have very shortage. We found in the future, we can expect a lot of shortage, and we need for pharmacy technician to help the pharmacist and leave the pharmacist to emphasize the clinically oriented and focus on something to prevent any medication error or drug-related problem for patient counseling. And this is very important now, at least to change and open pharmacy technician with the change of a curriculum, and instead of put it 2.5 years, a pharmacy technician, which this to looks like instead just 1 year pharmacy technician, and to be graduate, it can help the pharmacist. And this is our forecasting for pharmacy technician. For pharmacy, we need something for pharmacy education and training. And this is the survey, we have done it. And we found almost, we asked him how many pharmacists do you have pharmacy technician student program, job training program, residency, almost 40% they don't have a program. And we highly recommend to increase this percentage in the future. We suggested 2 ways. The first way is almost implemented, postgraduate year 1 and 2 or 3. It's almost in the United States, they don't have any 3. They have just 1 and 2. But here, they put it as 3, which is excellent. And I'm also suggest to make another channel for master clinical pharmacy and BH specialized clinical pharmacy to combine the clinical practice with the research. And we highly recommend to focus to the medication safety and a community pharmacy and related issue for patient safety, like pain management, anticoagulation. Some of them it's still currently now they are graduate, and some of them we need to expand, like community pharmacy, because now we're switching to the ambulatory care services. Almost I can guess reach to the 70% or 70% of our prescription to be ambulatory care or outpatient, and almost 25-30% will be inpatient. We need to focus on community pharmacy to be specialized in the clinical pharmacy and community pharmacy with a different specialty and sector. This if you can graduate, that means high knowledge, high educated, and high, and this one can push and prevent any medication error or expand medication safety. For total quality management, this is, I think, it's very important to implement in the pharmacy practice. And we ask our people with the same survey, do you have the total quality management? And almost it's a variable, reach up to 62%, but still some element does not exist. You need to expand it. You need to dig it more detail and for education, for implementation, to prevent any medication error, because a lot of them, including quality management indicator and services, should be implemented for all pharmacy practice and healthcare organization. Another thing which is very important, which Ministry of Health focus on it, patient satisfaction. They have a survey for patient satisfaction for all healthcare all healthcare services. But I would recommend to pharmacy to be to focus to the pharmacy practice. And we did a survey with the 3 hospitals for patient satisfaction for ambulatory care, and this study for 3 hospitals, and we exploring the patient satisfaction with a different domain, like medication availability domain, patient counseling domain with a different, and some of them they have get high percentage scoring of 5, and some of them very, very low. And this one, they can give you as a diagnosis as before medication error occurs. Be careful. This element you need very high to change, to update it. Otherwise, may this window tackle with the medication error in the future. This is very important. If you can make it annually, every 6 months, will be wonderful. And this is for patient satisfaction relationship. We ask about the pharmacists, how they deliver, their patient counseling, they are polite or not, how the teaching skills. It is very important to give you to see the feedback of the patient satisfaction and how much increasing by the time with the different survey and different times. Another thing for medication reconciliation, this is called detail for the something related to the allocation, to adherence medication, writing area, waiting area, everything. This is, I think, I'm highly suggest to be done for all pharmacy practice, including community pharmacy or ambulatory care. All of them should be done it and see the feedback of the patient and what's their suggestion, what they need. Are they satisfied? Maybe there is something I'm not familiar with. Maybe not satisfaction with the patient may lead to the or prone to the medication error and harm the patient. This is very important for patient counseling. I highly recommend, because patient counseling can can reduce a lot of medication error, because we found a lot of patients that are not familiar how to administer the medication. Just ignore, because what patients say to you, because the patient, they're coming to you and they will tell you, I read it in the internet, such and such, but you have to be sure that he understand very well what have he read, and you need to just to check with them. Did he read in appropriate way, in appropriate references? Did they understood very accurately or not? Because in the practice, I found a lot of people, they understood, or there is misunderstanding of some statement, and then I faced some of our family. They give the patient wrong dose, especially in pediatric and neonate, because I told them, why you give this dose? He told me, I read it in the pamphlet. I told them, this is wrong understanding. This should be such and such and such, and we change. I was changing the dose at that time. This is very important to be checked with the patient and educate a patient and family education, especially if you have handicapped patient, which is very important, because the handicap is a bigger problem. You need to sit down with the relative and give him full education to prevent. Don't expect that the patient, he has knowledge or high caliber. No. Most of our people, they are not familiar with the medication. Most of them. You need to be sure that everything has been dispensed properly and reached the patient in the right way, right time, right dose, and until reach to the the benefit and outcome and improve the patient clinically. I think what I'm suggesting, all the factor it's implemented should be implemented. Especially, I tackle some point with compatible with the Saudi vision, like new technology, like education and the training, like medication safety, patient counseling. All these as a part of strategic planning, which has been done and founded in 2013, and until now they are still implemented, which is very useful. I think I highly recommend all these parameters, and I wish to implement it anywhere or for all healthcare organizations. And thank you very much for your listening. If you have any question, I'm pleasure to answer you.
Thank you very much, Dr. Youssef, for addressing this interesting topic. Now we will answer the question. If you have any question, you can write in Q&A icon. اللي عنده أي سؤال ممكن يكتبه في البوكس اللي تحت. We have one question. Dr. Youssef, what should I do if I make a medication error that no one else knows about, but I appeared harmless to my patient? How are medication error detected? How does the law recognize and deal with medication error?
It should be there is a system, and we design a system for medication error documentation. And initially, it should be there is a form, and there is a form for Ministry of Health or for healthcare organization. You have put a system. You have to identify what the medication error. You have to classify the medication error, because some of them we call it it is missing or missing. It is not errors, just missing. And some of them, no, it's sentinel, lead to the death or admission to the ICU. You need to classify it, identify. You have to put a system. That means if you have found any medication error, you need to document it. The documentation, it is not against anybody. You need to be this information and this strategies, you need to distribute it for healthcare professionals. The documentation medication error is not against anybody. We establish a system for medication error to prevent it in the future, to prevent any medication error in the future, and to improve patient quality of life. This is very important. And once you educate, I highly recommend to be a job of pharmacists or clinical pharmacists to document all medication error, follow up and document it, and make medication safety committee discuss about the medication error, just monthly report, make a meeting on monthly basis, discuss what the solution, how can we prevent, how can we implement all the successful factors to prevent the medication error. Then you compare it before and after, and if you need any medication, like medication safety course. Medication safety course for all healthcare professionals and awareness of the staff is very important. You need to make a lecture for all healthcare professionals, including physician, pharmacist, and the nurse, how to prevent, tell them about the important medication error, how to prevent in the future. This is some element of the medication error program. You need to establish full program to prevent the medication. You cannot just, it's not a matter of the form and documented. No, it's a matter of full program. And I think if you can discuss, if you contact with me after lecture, I can provide you. If you contact with the Saudi Patient Safety Center, they can give you full information about medication safety program, including medication error prevention.
Thank you, Dr. Youssef. Another question: how we can find the policy for prevention of medication prescription error locally? The policy for prevention.
I think the SIBAHI standard it's a part of policy. It is standard, not a policy, but I think you can utilize it to make it as a policy. I think there is administrative health. If we go to the general administration of pharmaceutical care, I think there is a policy procedure of the medication error. If you can contact with them, I highly recommend to contact with them. They can provide to you. And also for Saudi Patient Safety Center, they have a policy or standard. You can utilize it.
Thank you, Doctor. How many medication in one prescription we can write? The other question.
Internationally, it should be just one item per each prescription. This is the ideal, but 1 to 2 sometimes is acceptable. Otherwise, more than that should be not. If you are using electronic, this is the best. Nowadays, I highly recommend to use electronic prescription or computerized in order entry, because whatever doing in the right handing, there are a lot of mistakes. Believe me, there are a lot of mistakes, and you can reinvent the wheel every time, because each report. I remember I worked as quality managing pharmacist before, almost 25 years back. And at that time, we are using just handwriting prescription, a normal prescription. Each month, I bring up report to our manager, the same mistake, missing of medication, missing of names, not clear, abbreviation, the same mistake. With highly education, with highly give him some courses, still there you will find it. But I remember we were converted to the electronic prescription. All the demographic information mistake has been stopped right away in one shot, because all information like patient information, sex and age and pregnancy, lactation, all these or any allergy, it will be stopped. It's very clear. You can find it in electronic prescription. I think handwriting prescription should be no more, should be now converted, because a lot of people now providing the electronic prescription, and very easy, either locally or internationally.
Thank you, Doctor. Muhammad Hamid asked, in everyday practice, we will be faced with the prescription error, and most are solved before getting to the patient. Is that a near miss?
I'm sorry?
Muhammad asked, in everyday practice, we will be faced with prescription error, and most are solved before getting the patient.
Yes.
Is this a near miss?
Yes, a near miss. Medication error occurred, but not reached to the patient.
Okay, thank you, Doctor.
More than medication error. If we have medication error program, you can find more than 70–80%, all of them near miss. More than 60–50%. 5% less than that, you can find no. It's in between until reach the sentinel. Sentinel evidence, if it's high, that means there is a problem in the medication safety program. You need to review all the safety program at your institution. But the near miss, it's healthy. This is normal. If it's increasing percentage, this is good. Your target to be 0 error. Don't tell I need percentage to reduce medication error from 35% to 10%. No. Medication errors, it's should be 0. Whatever you reach, it's better. If you reach the 0, it's excellent. But don't tell, no, I have a window of medication errors. No, this is not acceptable ethically. Should be 0 error. Whatever the strategic goal is very high, not reachable, but you cannot say I need 5% medication error. No, this is not acceptable ethically.
Thank you, Dr. Arafa asked how we can improve medication error reporting.
Just now we discussed with Dr. Rakan about reporting medication error. the standard or Sibahi or all the people for now quality management, they are recommend to make education, training, awareness. Personally, because I published before 2 years back about adverse drug reaction and physician knowledge of ADR or physician perception of ADR. What I found, two systematic review, and each one of them they are covering 20 years back, and now you can say almost two systematic review covering the past 40 years. They came up with the same conclusion: poor reporting of the ADR by physician and nurse, while the high reporting by pharmacist. And our author and our research team, we come up with the conclusion: the reporting of medication error, what I highly suggest, don't waste the time. Whatever you do education, you will find non-compliance. And I highly recommend all the documentation of a drug-related problem to be full transferred as a job of pharmacist. The physician, he just call you on the nurse, we have ADR, we have medication error, and let the pharmacist complete the job. Because whatever you are training, whatever you are providing, education, training, still they are missing. They are missing. I think it's a wasting of time in the past 40 years, and you come up with conclusion. All of them, all the systematic review, they stated poor adherence, poor reporting. Still, now what's the solution? Let's make another solution. Another solution that I suggest, highly suggest, to transfer all the job of documentation drug-related problem to the pharmacist, at the job of pharmacist, and physician or healthcare provider or nurse or pharmacist just call somebody in the pharmacy and tell them we found medication error. And the pharmacist, he go upstairs or go to the place of medication error and analyze all the situation and document it and ask physician and nurse, because the nurse and the physician, just recently we discussed with the emergency doctor. In the emergency, if you practice in ICU in emergency, do you think you have a time to document all medication error? It's incredible. It's incredible. This is not a practice, especially in emergency. Just I'll show an example. If you are practicing in the hospital, please visit the emergency section at your institution and see how the healthcare providers are working in emergency, especially in the evening and night. If they are crowded with the population, crowded with the patient, they don't have the time to document at all. And also because a lot of accidents, sometimes a lot of people, they are coming. It's emergency. Sometimes you discuss with the patient, and all of a sudden another patient fell down. Another patient, they need CPR. The other one, they need emergency. It's really a headache in emergency. I work with emergency 2 years, and then I work in ICU maybe more than 15 years. In an ICU, the same situation. As a critically patient, you cannot leave it. If you leave it, that means, shall I leave the patient care and go document it? I know it should be, but we don't have the time. I'm being realistic, especially if you have a job, you can transfer it to the pharmacist or another one. They can cover it very well, because all the reporting, they stated the pharmacists, they are better in the documentation, better than physician and nurse. Why are you still dumping the job to the physician and nurse? This is I highly recommend. After doing our research at that time, and we reported, please, our suggestion, just transfer all the job for documentation to the pharmacist and to the clinical pharmacist, and let them to follow up and document it. If they need any help, they can contact with the physician anytime, with the nurse, and if there is any missing information, then documented, and the reporting, then send the report to copy to the physician and nurse. And if you have a meeting, you can make a meeting in the medication safety committee and invite involved physician and discuss it thoroughly and suggest solution and prevent all the factor lead to the medication error in the future.
Thank you, Doctor. This is the end of the question. Um, For award, there is a registration for the fifth National Patient Safety Award is open with the shown tracks deadline for registration of is third is a 30th of September. Saudi Patient Safety Center reminds you about the coming webinar that is aligned with the World Patient Safety Day. Kindly find the schedule for webinars, and you may visit our SBSC webpage to view and submit. On behalf of the Saudi Patient Safety Center, we would like to thank Dr. Yusuf Al-Aoumi and the audience for their active participation. As a part of the Saudi Patient Safety Center's offer to provide you with timely topic and interesting speaker, we would appreciate it if you would fill out the evaluation survey sent to your email after the session. Thank you for joining us today, and we look forward to welcoming you back in future webinar. شكرا لكم ويعطيكم ألف عافية.
Okay, thank you very much for listening, and I appreciate it.